Okay, so we're going to begin this lecture on regulations and metabolism and regulation. And we're mainly going to be looking at a lot of the different hormones and things like that from the endocrine system that affect the body's ability to metabolize products. So quick review, this can be found in your McKinney book, chapter 51. I highly encourage you guys to take a look at this. Make sure that you're paying attention to the boxes, the tables. There's a lot of good information in this chapter, as well as in your ATI Nursing Care of Children book. Chapter 33 deals with diabetes, and then chapter 34 deals with growth hormone deficiencies. Quick little review of the endocrine system itself. So the endocrine system really is made up of several glands throughout your body, and these glands release chemicals like chemical messengers that we call hormones, and these can control and regulate the action of the target tissues or the things that they're trying to stimulate to working. So hormones can influence growth, they can influence development, they can aid in digestion, and they can also help regulate metabolism as well as reproduction. So the endocrine system and the autonomic nervous system, oftentimes they work together in this process. The autonomic nervous system transmits messages to the hypothalamus, which secretes the appropriate hormonal factors. The pituitary also can get involved in this. This is a gland that can also stimulate and inhibit the release of hormones as well. And the endocrine system maintains or helps us to maintain that homeostasis that we need in our body. So we have direct feedback that tells the gland to increase or decrease the hormone production so that the body can return to the normal homeostasis. So when the concentration of hormone reaches a threshold or there's enough of it, then it tells the hormone production that it's now time to turn off. So you always have to think about these systems working together when we think about the regulation and stuff of our hormone system. Is there's usually something that stimulates it first. Like I say, that comes from this autonomic nervous system or the pituitary type gland. Let's take a look at some of the different hormones. Really, this should be more of a review because I know you guys talked about this in second semester. So we're going to look at like the thyroid gland, the pituitary gland, the adrenal gland, the parathyroid gland, the pancreas, as well as the gonads, and how this relates to your hormones. So your thyroid gland makes your T3 and your T4, which both function to regulate carbohydrate metabolism, lipid metabolism, protein metabolism, as well as growth and development. Calcitonin, which also comes from your thyroid gland, regulates your blood calcium and also phosphate release from the bone. So calcitonin will help decrease the calcium levels by blocking the breakdown of your bone calcium so that osteoclastic activity in the bone. So it helps by doing that, but it also helps by preventing your kidneys from actually reabsorbing it. That's one way it helps to regulate your calcium levels. Your pituitary gland, which is actually divided into two parts. So you have your anterior pituitary and then you have your posterior pituitary. So your anterior pituitary produces things like your TSH or that thyroid stimulating hormone, which then goes on to affect your thyroid gland. And this stimulates production of hormones. Your growth hormone also comes from this, and it helps to stimulate protein synthesis, fat mobilization, decreases the use of carbohydrates, all of which help to increase the tissue growth. That's one of the things your growth hormone is responsible for. You have your follicular stimulating hormone, which stimulates the Graafian follicles to release the ovum in a female, and the seminiferous tubule development in males. You have LH or luteinizing hormone, which causes the follicle to rupture and release the ovum in a female and stimulates testosterone production in your males, as well as prolactin stimulates breast milk secretion. And these are all coming from the anterior pituitary. And then you have your posterior pituitary, which produces things like oxytocin for uterine contraction, as well as milk letdown during lactation. And finally, you have ADH, or the antidiuretic hormone, and this helps to regulate the concentration of fluids in the body. We talked about this this past week when we talked about syndrome of antidiuretic hormone, and you probably talked about this in your neuro lecture, as well as something called diabetes insipidus, which is also something that happens from ADH, or that antidiuretic hormone, not being released the way it should. Your adrenal glands are located, this is your moving on down now. Adrenal glands are located on the top of your kidneys, on each kidney, and they're comprised of two parts. There's the cortex, and then there is the medulla. So the adrenal cortex secretes aldosterone, which is responsible for renal absorption, or I should say reabsorption of sodium and excretion of potassium. Also, cortisol maintains a glucose control. It also increases hepatic glucogenesis and manages the stress response. Androgens are male hormones, or male sex hormones, I should say, that promote secondary characteristics. And then you have the adrenal medulla, which produces things like some of your catecholamines, which include things like epinephrine and norepinephrine. And then we have the parathyroid gland, which this also helps to maintain calcium levels in the blood, and it also can inhibit phosphorus reabsorption. The pancreas, which contains a cluster of cells called the islet of Langerhorn, and these cells produce insulin, glucagon, and somatostatin. And then finally we have the gonads, which are sex glands, and these can include the ovaries, which produce estrogen and progesterone, and the testes in the males, which can produce estrogen. Okay, so we're going to look at some quick differences, or some important differences in your pediatric endocrine system, such as the endocrine system is less developed at birth than at any other time in the body, and hormone control of many of the body functions is lacking until the child reaches the ages of about 12 to 18 months. And then infants may manifest imbalances in concentration of their fluids, electrolytes, amino acids, glucose, and trace substances, which this can make it much more, difficult for us. And this is why kids tend to get sick, and we have to kind of step in and regulate some things for them because these systems are immature. Okay, so here are some of the genetic metabolic conditions that we can see in children that can require long-term management, with the galactosemia being the first, maple syrup, urine disease, Tay-Sachs disease, and then PKU, or fancy name is phenylalanine hydroxylase deficiency, or it can sometimes be abbreviated as PAH deficiency, and also congenital adrenal hyperplasia and congenital hypothyroidism. So just briefly on this galactosemia, it is a rare condition in which infants are unable to digest milk or sugar. So these children are often are placed on a lifelong lactose restricted diet, and if left untreated, this condition can actually result in death of the child. Maple syrup urine disease, this is something that is also rare, as well as the galactosemia. They are both rare conditions. And in the maple syrup urine disease, you have a buildup of amino acids that causes ketoacidosis, which appears soon after birth. The infants are usually lethargic, they don't feed well, they can experience seizures and loss of reflexes. Their urine oftentimes smells like maple syrup, hence is the reason it is called maple syrup urine disease. And death can occur quickly. So this child is placed on dialysis and a lifelong protein-limited amino acid type diet. And then we have Tay-Sachs disease. This is a genetic condition that primarily affects infants in the Ashkenazi Jewish population. This is caused by abnormal buildup of gangliosides in the neurons, and the infant usually develops normally at first, and at about 6 months of age they start to display some developmental delays and then have some progressive neurodeterioration. I know looking at the developmental test, the first test, and some of those developmental things, there was a question on there about developmental regression. And one thing you don't want to see in a child is regression in neurological function. So if a child is able to, crawl or walk, and then they regress back, so they're suddenly not able to crawl, or if you have a walking child that suddenly can't walk and they're crawling, That's never a good sign. Children should not do that as a form of regression. That's usually showing some sign of neurological impairment, so we don't ever want to see that. The infants with this Tay-Sachs can also exhibit some macrocephaly. They can have seizures, they can develop blindness or deafness, and they usually die early in childhood with this particular disease. And the next three we're going to look at on the upcoming slides. Let's talk about this phenylalanine hydroxylase deficiency, or PKU. This is an autosomal recessive disorder that encompasses a group of diseases occurring due to a dysfunctional phenylalanine hydroxylase enzyme that is used to convert the phenylalanine to tyrosine. And this is important because tyrosines are essential for the protection of several of our important neurotransmitters, such as epinephrine, norepinephrine, and dopamine. And this results in accumulation of the phenylalanine in the body that progress to mental impairment. So some of the signs and symptoms that you can see are delayed for a few months, but oftentimes they lead to digestive problems. They can develop a musty odor to their urine. They may develop eczema on their skin. They can have hypertonia, seizures, hyperactivity, and intellectual impairment. All newborns are screened, or they're required to have these screenings done before they leave a hospital. And this is usually done by sticking the infant's heel, and they fill these little spots on a special paper, and then that paper is sent into the state. This is mandatory testing that is done at a hospital. Dietary management must be started as soon as possible to reduce the CNS damage. And the diet is low phenylalanine and also protein restricted. And then serum testing continues throughout the lifespan of this child or this person to monitor they call it a PHE level, which is just that phenylalanine level. And treatment does last for their entire life. Let's take a minute to talk about some congenital adrenal, or something that's called congenital adrenal hyperplasia. This is an autosomal recessive disorder. The adrenal gland does not make adequate cortisol, and while working to produce cortisol, it produces excess androgens or sex hormones. So the manifestations can include things like ambiguous genitalia in females, postnatal virilization in both sexes, and something called salt wasting crisis. In infant girls, they may require reconstructive surgery, and of course the parents are going to need support and reassurance because this is kind of scary for them, because the ambiguous genitalia in female may mean that their sex organs did not appear to really grow properly, so hence is the reason they're doing some reconstructive surgery. Viralizing refers to the development of a mascular body. So in these girls, they may take on some characteristics due to the male hormones being produced. So they may look muscular, they can have an advanced bone age, and they can also develop premature pubic hair. Salt wasting crisis, this is manifested by low serum sodium because what's happening is because of the way the hormones are working, the body cannot retain the sodium, and so it's lost in the urine. That's why it's called wasting, salt wasting crisis, is because they're retaining it in their urine instead of being able to actually absorb it back in. So some of the things you see are low serum sodium. They can have high potassium. They might be hypovolemic, and eventually they'll go into a hypotensive crisis because of the low volume. This condition does require replacement with corticosteroids in order for the child to survive. And children that receive the glucocorticoid replacement therapy need to be regularly assessed for linear growth as well as signs of early puberty. And they will need to continue to follow up with an endocrinologist for the rest of their life. And that follow-up is very imperative to their well-being. Congenital hypothyroidism is just exactly what it sounds like. It's hypothyroidism that is present at birth of the child. So the thyroid gland just does not produce enough of the thyroid hormone to meet the body's metabolic needs. So this is one of the tests that is detected on newborn screening that is done before discharge. And the way they do this is they check the TSH level, which if you go back to last year's lecture, that makes sense because, you know, when we're looking at hyper and hypothyroidism, they use the TSH. And so if I was doing this in class, I'd ask you, what would you expect the TSH to be? You need to kind of think about it as reversing the thyroid. So it's kind of like if the TSH is elevated, that means that the thyroid is not producing because it realizes it needs more, so it produces more thyroid stimulating hormone to try to stimulate that thyroid. So you would expect the thyroid or that TSH level to be high in these children. So some of the signs and symptoms that you may see are things like skin mottling, large anterior fontanelle, and that usually closes, you know, later in life on this child. They may have a large tongue, so their tongue appears like swollen or edematous. They will have hypotonia, slow reflexes, distended abdomen, as well as kind of a hoarse voice. In your book on page 1250, you get a good picture of what a baby looks like with this condition, and you can definitely see the changes that you would not normally see in an infant. And then they also have a picture of this same baby after receiving therapy, and you can see the changes that occur. We'll talk more about something called mixed edema coma when we get to fourth semester. And it's in an adult, and they oftentimes look very much like this baby in picture A in your book on 1250 with that big thick tongue and kind of the swollen looking face and stuff. So treatment for these children consists of lifelong thyroid replacement therapy, and it needs to be started as soon as possible to avoid any kind of intellectual impairment or growth slowdown in these children. We have acquired hypothyroidism, which is simply that they've acquired the inadequate production of thyroid hormone. And this can be calls for something called Hashimoto's thyroiditis, which is an autoimmune process and is usually associated with a goiter or an enlarged thyroid gland. This is one of the common causes of acquired hypothyroidism. Other causes may be things like surgical thyroidectomy. They've removed the thyroid. They've had radioactive iodine therapy for hyperthyroidism. They may have had radiation therapy due to malignancies, or they could have had excessive iodine ingestion. So in Hashimoto's disease, it's actually an autoantibodies. They come in and they decrease the production of that T3 and T4, and then they generally develop a goiter or that enlarged area in the thyroid gland. So some of the signs and symptoms that you'll see other than the goiter are things like dry, thick skin, coarse, dull hair. They may be tired all the time. They usually don't tolerate cold weather. They have a cold intolerance. They may have edema or swelling. They may have constipation. They can gain weight, and they don't have good linear growth, or they have decreased linear growth where they're just not growing properly. So management, again, just involves thyroid replacement, usually with levothyroxine. That's usually the drug of choice, and the doses will vary, of course, according to the age and the weight, and will have to be titrated as the child grows. With proper treatment, the goiter should eventually decrease in size, and those signs and symptoms should start to resolve. Okay, so now that we've talked about hypothyroidism, whether it's acquired or congenital, we're going to flip sides now and talk about hyperthyroidism. And the most common cause of hyperthyroidism in children is Graves' disease. And Graves' disease is an autoimmune condition in which you have excessive thyroid hormones that are being produced by an enlarged thyroid gland. So again, you're going to see goiter with this patient. You can see goiter in somebody whose thyroid function is normal. That's hypo or hyper. It just can happen. So note that the goiter, it can be present, like I said, in either of them. I'm going to tell you that on page 1251 there's a box for differences in hyper and hypothyroidism that would probably be good to look over. There's also, I know on page 1251, they talk about the nursing care of taking care of these patients like with hypothyroidism. And then on 1252 there has nursing care, and 1253 about child with hyperthyroidism. It's got a lot of good information in them. But one significant manifestation of Graves' disease is protrusion of the eyeballs. This is also known as exophthalmos, where they kind of have that bug-eyed appearance. And this is not something that is reversible with treatment. So some of the other things that you may see are increased appetite. They'll lose weight, and they'll have heat intolerance as opposed to cold intolerance. They may be tachycardic or have heart palpitations, and then that prominent eyes, which I've already mentioned, or that exophthalmos. So treatment is medical with anti-thyroid meds, or they may do an ablation with radioactive iodine, or they may do surgery. Methimazole is the drug of choice for treatment for this. Its action is to block the production of the thyroid hormone. The second treatment option is the radioactive iodine that is given as an oral solution. This is absorbed by the thyroid gland, and then it destroys the thyroid tissue over a period of several weeks. Hypothyroidism can then develop and require treatment with replacement therapy, so they may go from one extreme to the other. And then the third treatment is subtotal thyroidectomy, or removal of the thyroid. And this also has some risks, and their calcium levels need to be monitored, because keep in mind from one of those first slides we talked about, your thyroid is also responsible for calcitonin secretion. So if that's gone, then we have to worry about the calcium levels in the body. Okay, so we've talked about thyroid and some other of the hormonal imbalances. We're going to switch now and talk about something that affects the ADH, or the anti-diuretic hormone. Like I said earlier, I know we've talked about SIADH in class last week as it related to oncology. And I know you've talked about diabetes insipidus in your neuro lecture, but we're going to talk about it again as it pertains to children. The disease process is still the same as it was. This is the inability to concentrate urine, and this is simply because of the retention, I should say, or the under secretion of antidiuretic hormone. And so because that when you see this, two of the common or classic signs and symptoms are that they have polyuria and polydipsia. So they can put out copious amounts of urine, and when they do that, everything becomes very concentrated. So you see hypernatremia, and you see dehydration in these children because they're excreting so much urine. And keep in mind, depending on the age, dehydration can be deadly to anybody, but it can happen rather quickly in your younger children because they don't have that reserve. So it's something that we definitely have to keep an eye on. This can be an inherited thing, or it can be acquired. Still, you're going to see it with some of the same things you see that we've already talked about, whether it's cancer diagnosis or with like head trauma. I always think about diabetes insipidus when I think of a head trauma kind of thing. So when we're talking about this, we've already talked about the polyuria, the polydipsia, meaning they're peeing a lot, they're wanting to drink a lot. Some of the things that's very diagnostic with this is that you'll have hypernatremia with levels above 150. You'll also see them have a low urine specific gravity of less than 1.005, as well as their serum osmolality will be greater than 300 in the absence of hyperglycemia. So as far as treatment goes, what we want to do is, of course, you're going to have to do fluid balance and get them hydrated back up. They may give synthetic vasopressin, and this can be given 1 or 2 times a day. It can be given intranasal, or it can be given oral, and this just helps to decrease that urine output. The bad thing about this is overtreatment with that synthetic vasopressin can result in fluid retention, which then can swing them into hyponatremia, and they can develop seizures. So family education is very important for these patients, and correct administration of the medication is a priority of nursing care, and also discharge teaching. So when you're talking about this and you're seeing a child who's going to the bathroom a lot, and they're drinking, you know, one of the things you want to make sure you teach them is if they suddenly see a significant decrease in the amount of urine that's being put out, that is cause for concern, or cause that would be something that they would need to let us know about, because like I said, we don't want to send them the other way. And so since you're not in the room all the time, it's just some of the things you want to make sure that you're teaching these patients. I do want to draw your attention to box 51-2 on page 1253. It's just a nice little box that gives you a comparison of diabetes insipidus versus SIADH. So it's a good little quick reference for you guys to look at. We're going to talk about syndrome of inappropriate antidiuretic hormone, where they're just producing too much of this ADH, which leaves them with the inability to excrete water. They retain water, they hang on to it. I've already kind of told you about the box on 1283, but something to keep in mind is diabetes insipidus is considered high and dry, meaning the serum sodium goes up and they dry out because they're peeing. They're doing a lot of urination. And SIDH is low and wet, meaning that serum sodium level drops and they're wet because they're retaining fluid. So high and dry for diabetes insipidus, low and wet for SIADH. So usually with this one, the most common cause in children is excessive use of that vasopressin in the treatment of diabetes insipidus. But some other things that can cause it are some CNS infections like a brain, like meningitis, encephalitis, things like that, brain tumors and seizures. Manifestations you can see on the slide, hyponatremia, they will have decreased urine output, increased urine specific gravity, as well as increased urine osmolality, while they'll have a low serum osmolality. They can also have hypochloremia. They will have fluid retention. They will gain weight because of the fluid maintained in the body. So some treatment is usually the correction of the cause, if you know what that is, fluid restriction, and also IV fluids to correct any hyponatremia, very slow. And this is kind of like I talked about last week, is they would give a hypertonic saline solution to try to counterbalance that. So some nursing care will include assessment for signs of fluid overload, so things like edema, weight gain. You're going to be watching that urine-specific gravity. You want to do good, accurate I's and O's. Seizure precautions, because that is something that can happen when that sodium dips low. So you have to put that into place. And diet should include foods with high sodium content. So just a few things to think about. I'm going to switch gears again, and now we're going to talk about something that has to do with your gonadotropin releasing hormone. So this is precocious puberty, or early onset of puberty, and this usually is considered before age 8 in girls. In the Hispanic, people with Hispanic ethnicity or African American history, it's usually around the age of 7.5 as opposed to 8 years old in a girl, and then it's 9 years old in boys. It's 10 times more likely to appear in girls than it does in boys, and it is simply defined as premature appearance of secondary sex characteristics with accelerated growth rate and advanced bone maturation. And one of the major consequences is that early growth plate fusion due to the advanced bone maturation, because once those growth plates fuse, eventually lead to short stature in adulthood because the bones are no longer able to grow. So we have something called central precocious puberty that can be idiopathic, or we don't really know what the cause is, or it can be caused by a tumor in the CNS or the central nervous system. Excuse me, head trauma, infection, something called septo-optic dysplasia, which is a condition that affects the optic nerve and can lead to blindness. It can be from genetic mutations or from cranial radiation. It is sometimes associated with some genetic syndromes. And then there's peripheral precocious puberty, which is much less common than the central. And this is usually a result of congenital adrenal hyperplasia or abnormalities or tumors of the adrenal gland, ovaries, or testes. Excuse me. Diagnosis is usually made with something called a gonadotropin releasing hormone analog, and this is administered IV or sub-Q to stimulate the release of the luteinizing hormone and follicular stimulating hormone from the pituitary gland. And samples are then obtained, and if they are in early puberty, the LH will peak higher than the FSH will peak. X-rays are also used to help diagnose this, and it's usually done by doing X-rays of the wrist to determine bone age. The primary goal of treatment is to preserve adult height. So gonadotropin-releasing hormone blockers are used to inhibit the binding of that gonadotropin-releasing hormone to the pituitary gland. And this causes a decrease in production of hormones and then slows or reverses the sexual development. These medications can be administered by either an IM or subcutaneous injection, and this will help suppress that gonadotropin releasing hormone production, usually within 2 to 4 weeks of its initiation. But something important to note, and this is something that parents definitely need to be taught because compliance is so very important with this, is that if the dose is missed or delayed, it can actually promote puberty changes rather than suppress them. So it's really important that they have a good understanding of the treatment because we don't want things to get put off and then have an adverse effect. And in your book on page 1257, there's some good things on nursing care for the child with precocious puberty that you can review. Now let's look at growth hormone deficiencies. So this is an inadequate production of or secretion of growth hormone, which causes poor growth and then short stature. It can be an isolated condition, or it can be associated with other conditions such as hypopituitarism, congenital malformations of the pituitary gland, could be due to a brain tumor, or again from cranial irradiation. Boys are more likely to be diagnosed and treated for growth hormone deficiencies than girls. And so some of the manifestations include height below the 5th percentile. So for those of you who've done pediatric rotations, if you've ever seen them use growth charts, or they have some kind of way of measuring, comparing to other children, they fall within that 5th percentile. They have diminished growth rates. They could be immature or have cherubic facial features, like they're just not maturing. Delayed puberty, hypoglycemia, which that's kind of important to know. We don't want them walking around with low blood sugars. Diminished muscle mass with increased body fat. They could have micropenis in your male clients. So diagnosis is usually made over a period of 6 to 12 months with growth being evaluated. They can do some screenings, including things like thyroid function tests. They may look at their electrolytes, assess renal function by looking at the BUN and creatinine. They'll check their CBC. They'll check insulin-like growth factor, or IGF-1, I think was what your book calls that, as well as the IGF binding protein. And they will also, again, do some bone age radiographs where they're taking x-rays of those bones and assessing growth plates and stuff like that to see where they are. So some things that they might, agents or whatever, to stimulate growth hormone production are usually given so that the serial levels can be obtained to confirm diagnosis. Children with growth hormone deficiency are usually given a subcutaneous injection daily for replacement therapy, and the response to the growth hormone replacement therapy is most evident usually within that first year, and then will start to diminish. The therapy will be continued until the growth plates in the bone closes or the child reaches the acceptable final height. So again, they'll be reassessing those bone radiographs or x-rays. That's just another name for x-ray. So nursing care for the children includes consideration of self-esteem and body image concerns. You know, I can see with this happening much more common in boys. You know, for boys, they always want to be big and tall, or most of them think that's what they want. So sometimes being of shorter stature can kind of, you know, mess with their self-esteem and how they perceive their body image. It's one thing for a woman to be, you know, petite, but for males, this can be kind of traumatic for them. So teaching for the child and the parents are for appropriate medication administration and the importance of monitoring growth. Because keep in mind, these do require daily injections for replacement therapy, so this is something that the family will be taught to do. Okay, so now we're going to talk a little bit about diabetes mellitus, or diabetes. This could be type 1 or type 2. So you should already be aware of that there are those two types. Both of them do involve abnormal carbohydrate metabolism and hyperglycemia. In type 1, beta cells are destroyed by an autoimmune process. Genetics do play an important role, but environmental triggers such as things like viral infections, this could be like Coxsackie bee, mumps, and congenital rubella. Dietary toxins and chemicals and history of obesity can also contribute. Children with type 1 diabetes are prone to the development of other autoimmune conditions such as Graves' disease, which we talked about earlier, Hashimoto, and celiac disease. So in your type 1 diabetics, you oftentimes see the 3 Ps, which are polyuria, polydipsia, and polyphagia. So they drink a lot, they urinate a lot, and they want to eat all the time. They also will have weight loss. They may have frequent infections. They can have delayed wound healing. They're oftentimes fatigued or very tired and may complain that they have vision that is blurred. With type 2 diabetes, this is more of a slow onset, which you should know a lot of this from stuff you learned last year. This one is usually manifested by that polydipsia and polyuria, where they still are wanting to drink a lot, they're still urinating a lot, but they also may have frequent yeast infections and delayed wound healing. Type 1 is the most common type in children, but type 2 unfortunately is becoming more prevalent, and this results from the increase in childhood obesity that we're seeing. So it's kind of sad, but we're seeing more and more type 2 diabetes develop in young children. So diagnosis for type 1 is usually made with laboratory tests and values with a hemoglobin A1C that is greater than 6.5%, or a fasting blood glucose of 126. And they'll do a 2-hour glucose tolerance test that is greater than or equal to 200, or a random serum glucose that is greater than 200. Children with type 1 diabetes are managed closely, usually with a team of experts, so they'll have doctors, specialists that they will see. Insulin therapy is the primary treatment for type 1, which is same to what you see with our type 1s as adults. And goals for the long-term management are facilitating adequate growth, maintaining an age-appropriate lifestyle, and achieving a normal A1C within a minimal number of hypoglycemic events, and just prevention of acute complications like things like DK or diabetic ketoacidosis, which can lead to death if not managed properly. Also with our type 1 diabetics, no insulin is being produced, and you probably should remember this from last year. So initial treatment is with insulin, and this can actually result in what we call the honeymoon phase, which is characterized by the the child needs less and less insulin as they're getting it. And this can last up to about 7 months, but that can vary a month or two. But they kind of get sometimes thinking like, maybe I'm not going to need this because they keep decreasing my insulin, so maybe I'm not going to have this for life. But that does not mean that the diabetes has resolved. When you're treating them, synthetic human insulins are usually what is recommended for children. So types of insulin doses and schedule of injection is, determined based on what that child has needs for, and they will still need to do daily glucose monitoring. So a lot of education, again, with these patients and with their family members. This one's kind of a hard one too for kids because it makes them somewhat different. They may have to wear monitoring devices. Some children, when I worked as a school nurse, I had a couple children that had to wear insulin pumps. Most children don't like things that draw attention to themselves, that make them stand out. And so just making sure that they understand the importance of that and why they have to wear those pumps or have to do the insulin injections. It's just kind of a big thing. We're going to, you'll see the activity that we're going to do in class. We're actually going to do something with DKA to hopefully provide you guys with a little more information about diabetic ketoacidosis and what that means for the patient. Because if the insulin goes too high, they can actually start breaking down proteins, which then spill ketones, which leads to acidosis. And so these children can get in trouble, and they can get in trouble quick. So we're going to do something on learning how to manage that in class. So we're going to talk just briefly about some of the different insulins. This should be more of a review for you guys. You had rapid acting, we have short acting, we have intermediate and long acting insulins. With your intermediate and your long acting, those are usually the ones that we consider, quote, cloudy insulins. So administration of insulin usually involves a combination of intermediate or long acting and rapid or short acting insulins injected multiple times, usually before meals and snacks. So some children, like I mentioned before, they may be managed by insulin pumps, so they may actually have to do injection. So it is important that the child understands that they're doing rapid acting insulin, that they must eat within 15 minutes to prevent hypoglycemia, because that's how quick rapid acting insulin starts, is within about 15 minutes. Your long acting down there at the bottom, this glargine, is also a long-acting. It's a peakless analog that is given in the evening for children ages 6 and older. It is complemented during the day, usually with a rapid-acting insulin when the child consumes food or carbohydrates. One thing to note with the glargine is you do not mix this with any other types of insulin in a syringe. So I know they teach you how to mix, your insulins, but this is one of those that you do not mix. Okay, so do not mix this one. Another thing that's important for you guys to understand is regular insulin is the only insulin that you can give IV. So of all these types of insulin, the only one that can be given IV is regular insulin. This is so important for you guys to know this. NCLEX expects you to know this. I've seen several questions about this, so it's very important that you understand that that is the only one that can be given via IV. Another thing that's important to teach is that rotating your injection sites is so very important to prevent adipose hypertrophy, which could interfere with the absorption of the insulin. So this is why we teach patients to rotate their sites so that they get good absorption every time, because we want them to have good glucose regulation. Okay, so it's important that you understand the emergencies that can go along with diabetes, and so that you're able to teach the families on how to manage these medical emergencies. So signs and symptoms of hypoglycemia, which is the first one there. can include things like sweating, the patient feeling very lethargic. They may act confused. They may be hungry. They can be dizzy, or they can also just feel weak. So immediate treatment includes administering like 4 ounces of juices, several hard candies. You may encourage them to have glucose tablets or glucagon injections, which this just causes the liver to release glucose at glucagon. So signs and symptoms of hyperglycemia will include fatigue. They may have a headache. Their vision may be blurry. They can have dry, itchy skin. And the symptoms indicate the need to adjust the type or dose of insulin or adjust meal planning. Management of diabetes on days when the child is sick, or quote, those sick days, require communication with the healthcare team because they're going to have to help manage this child's care. Usually insulin doses and regular meals should be given as usual if possible, but they do need to frequently monitor that blood glucose and urine for ketones when necessary because it's not uncommon with infections or sickness for glucose to go up. They will become hyperglycemic. So you do want to encourage them to rest and know that the insulin regimens that they're on may need to be adjusted by the provider during these sick days. And then finally is DKA, or diabetic ketoacidosis, and this is a severe insulin deficit leading to hyperglycemia, the presence of ketones in the blood, and development of metabolic acidosis. Like I said, the body just starts breaking stuff down and it just starts spilling these ketones out. And these patients will develop a metabolic acidosis. And up to 40% of children with a new diagnosis of type 1 are experiencing DKA. So the parents and the child don't even know that the child has diabetes. The first thing they find out, or the first time they find out, is when the children becomes very sick with DKA. So some of the signs and symptoms include abdominal or chest pain. They may be nauseous. They may throw up. One of the hallmark things is something called a fruity smell breath, acetone breath, rotten fruit breath. Once you've smelled it, you don't forget what it smells like. They can also have decreased level of consciousness. They will do something called Kussmaul respirations, where they're just doing these really heavy kind of thing. And if you think about the fact that they're in an acidotic state, that's a compensatory mechanism. They're trying to blow off that excess CO2. That's why their respiration pattern changes. They will have constant urination or a lot of urination. They will have signs of dehydration due to the constant urination. This is a life-threatening emergency, and this does require admission to an ICU for close monitoring and administration of IV insulin, which means we're giving what kind? We're giving regular kind of insulin. So we will definitely talk more about DKA in length when we get to fourth semester, but just know that this is a very, very serious complication that is definitely a medical emergency in a diabetic patient, because DKA can actually lead to death in patients if not treated quickly.